want to introduce our next speaker and presenter. His name is Dr. Jeffrey Gauvin. He's the Associate Professor of Surgery and the Program Director for the Department of Surgery Residency Program at UC Davis Medical Center. He's going to talk to us today about what it takes to become a surgeon.
Thanks for tuning in out there on the internet. So my name's Jeff Gauvin. I'm going to make this very informal, and I'm going to go through and talk to you a little bit about what it's like to be a surgeon, what it takes to become a surgeon, some of the myths about being a surgeon, and what my life is like as a surgeon, because I think that's important for people. I just ran into somebody out in the hallway that said they didn't want to be a surgeon because he had to work full time. I do work full time. I think if you don't want to work full time, you shouldn't be a doctor. That's my first point, but it doesn't mean I don't have a life. I've got a great life outside of medicine too, and I think that's important for young people today, and I want to share some of that with you today, okay? Well, let me go back. This is the first night that I was ever on call as a brand new surgeon. So I'm a general surgeon. I did some other advanced training in gastrointestinal surgery, but as a good general surgeon, I do trauma when it comes in, and or at least I did. And this is a little boy that was stabbed by his brother with a steak knife. And this is me here. My first night I was a little bit nervous because I had to take care of this kid. And as I looked at this kid a little bit closely as he was laying there before they took him into the operating room to put him to sleep, every time his heart would beat, the handle on that knife would shake back and forth. And it would shake back and forth. And all I could think of was when we pull that out of there, all hell's going to break loose, because it was probably very close to his aorta, which is the biggest blood vessel in the body. So I was pretty worried about that. But fortunately, we did all the right steps, and everything came out okay. So one of the things that this exemplifies is when you train to be a surgeon, there's no chapter on how to take a knife out of a little kid's back. But what you do is you learn some basic principles that you learn, and then you sort of take that with you, and you adapt that to the different situations that you encounter. And that's part of what I like about being a surgeon, is it's very diverse. You do lots of different stuff. And I'll show you some slides in a little while about some of the different interesting cases that I've done. So how do you become a surgeon? So I know right now many of you are just kind of at that point of, gee, I just want to get into medical school. And that's, of course, the big hurdle. But once you get in, the next big hurdle is what do I do, and how do I get into that? So I'll tell you a little bit exactly about what it takes to be a surgeon. And I don't think it's quite like how it is on TV. So the first thing you have to do is complete medical school. And as all of you know, that takes 4 years. And then after that, you have to apply and get accepted into a general surgery residency program. And that's a total of 5 years after medical school that you have to train to become a board-certified surgeon. Some people choose to go on and get some additional training. They choose to go on and do a fellowship training. Maybe they want to be a cardiothoracic surgeon, or a vascular surgeon, or a colorectal surgeon, or a designated trauma critical care surgeon. And they'll go ahead and do a 1 to 3 extra years of training beyond that, okay? But remember here, although that sounds like a long time, those 5 years that you're training to be a surgeon are the fastest 5 years of your life. And you're a doctor, right? You're getting paid to take care of people. You're still learning, but you're in the hospital, you're laying hands on patients, and you're learning how to operate. And it's a very exciting time in your life. So I'm the residency director at UC Davis. I have 69 surgery residents that I'm in charge of that are training to be surgeons. And it's a privilege to sort of follow them through all the different years that they train to become grown-up surgeons, and to finally watch them graduate. So that's a big part of what I do. So I can speak to you if you have any questions about what do we look for in medical school applicants that are trying to become surgeons. This is what I look for in an applicant. So coming up here in the next several months, I'm going to have about 90 different students from around the country, medical students, that'll come into my office, and they'll sit in the chair across from me. And they're trying to figure out if they want to come to my program to train to be a surgeon, and I'm trying to figure out whether or not I want them to be there. So these are some of the things I look for. I look for a team player. I want somebody who gets along well with people and knows how to interact in a group. Surgery is very much a team sport, from the person who cleans the room to the anesthesiologist, to the nurses that help, and to all the technicians, and for the people who wheel the patients in and out of the operating room. So it's a big team sport, and you need to get along well and work well with other people. I want somebody who knows how to work hard, okay? Everybody tells me they know how to work hard, but when I say, tell me a story in your life where you had to work really hard, it's amazing how some people don't have a good story. So personally, I like to see people that have got some jobs where they've worked really hard. I worked a lot of non-sexy jobs in my life. I was a busboy. I was a waiter. I roofed houses, I painted houses, I worked in the auto factories. I was a bouncer in a bar when I was in college. I did all these crazy things to get myself through school, and I actually think all those experiences make me a better physician. So I like that. Sometimes people don't put that on their resume. They think it's not sexy. And all that stuff on TV you see about surgeons and doctors is really sexy. But really being a surgeon, a surgical intern especially, your first year out, there's nothing sexy about it. It's come in early and you work really hard and you go home late. And so I want to see somebody that's got a good work ethic. And I like to see people that have had, maybe they put themselves through school or helped put themselves through school. And that's one of the things I really like to look for. It's not a deal breaker, but I want to know that you've worked hard in your life somewhere along the line. Volunteer experience is good. You know, they'll tell you how important it is to volunteer, but what happens if you come in 10 minutes late and you're a volunteer? Anybody know what happens? Nothing. You come in 10 minutes late and you're a waitress, what happens? Every day you lose your job, right? You come in 10 minutes late and you're one of my residents, you're going to lose your job. So I want somebody that knows how to work hard and come in early. Do you agree or no? In the last row, no? Okay, good. That's okay. You need to have solid grades in medical school. Certainly help. It's just like getting into medical school, right? So really good grades make it easier to get in. So the better your grades are in medical school, the easier it is to get into a surgical residency. And there's actually been studies to show that if you've had some leadership roles, that you'll be a better surgeon, a better surgical resident. So those are all things that I tend to look for. Well, when do most students decide to become a surgeon? So a lot of people now say, oh, I want to be a surgeon, and you might get accepted to medical school next year, but you'll probably change your mind a lot. And I've actually studied this, and this has been published in several different studies. This is some data that I collected on a study that I was doing. So this is when do people make up their decision about what kind of doctor they want to be. And only about 10% of you really right now actually know what you want to be. All right? You'll probably change your mind several times as you go through medical school. But clearly in the third and fourth year, so towards the end of medical school, most of you will decide in your third or fourth year of medical school what you want to be. Okay, so that's when most people decide when they want to be a surgeon, or anything else for that matter. Well, what's my week like? This is where I work at UC Davis, and I'll share with you a little bit about what my typical week is. So Mondays are the day that I operate. I'll operate this Monday. I think I have 5 cases scheduled to do. Sometimes I do anywhere between 1 really big case to 5 or 6 smaller cases. Okay, so that's my typical day. On Tuesdays, I see patients all day in clinics, people that I've operated on or people that I'm going to operate on. Wednesdays, I operate part-time, and I have some administrative time where I'm in my office in the afternoons. Thursdays, I have clinic in the morning, and then Thursday afternoon, I have to myself to do administrative things. And then Friday, I have a day to do administrative. Now, when I say administrative, I'm teaching a lot. I'm giving lectures. I'm doing stuff like this, stuff that I enjoy. Okay, I might be working on a research project, or I'm working with the administrative things it takes to run a residency. And on the weekends, I do whatever I want most of the time. Every once in a while, I have to do call on a weekend, or I volunteer today to come here and talk to you folks. But this is what I wanted to do today. So most of the time on the weekends is to myself. These are some of the typical cases that a general surgeon will do. When I'm on call, I do appendicitis. If you have, it's the number one most common emergency case that we do. We do a lot of gallbladder surgery, hernia. We take out cancers in the colon, the stomach, the liver, the pancreas. Trauma, certainly when we're on call. And I've done some robotic surgery. There's probably be a whole other lecture on robotic surgery. And that's where the surgeon sits at a console and sort of operates the arms of that robot. And I've done some of that. And so that's something that we do, and it's kind of fun. These are some of the interesting cases that I've done. I didn't know how much stuff. I did this last year, and they wanted more gory pictures, so I added a few good pictures. I hope you like it. So this goes back to the robotic surgery that I told you that I've done. And again, the robot doesn't do the surgery. The surgeon sits in a little console about 20 feet away and controls all the arms and does the surgery. So that's something that's kind of new and coming on the scene right now. This was probably the most interesting case I ever had. Was a little 11-year-old boy back when I was in Michigan, and he was driving in a car in a tree. There was a storm out. A tree broke through the window, crashed through the front window of the car, and came through the window and impaled this kid in a chair just like this. He came into the emergency department like that. It looked like a little piece of shish kebab sitting on a chair, and they unscrewed the chair and brought him in to the hospital in the chair because they didn't know what to do. And we took that chair off in the operating room. And this is a picture of the stick. It's about as big around as my arm, and it went all the way through that kid's belly. And there's the chair he was sitting in, and that's, you can see here where it's coming out the front and the back of the chair. And this is him about 6 months later. It's not a pretty scar, but you don't get a pretty scar from something like that. And this is where the stick had come out in the back, and that's him. And he did great. When I saw him, he was playing football and doing great. He and his family and I went out to dinner after that. It was kind of neat. He gave me, this happened right around Christmas time, and he gave me a T-shirt. It said, Dr. Jeff 1, Tree 0. I thought that was pretty cool. So that's probably my most interesting case, but I got a few other ones. This was kind of interesting. This was a guy that was out fishing. They had this big spear, and they were coming back on a little ATV, and they hit a bump, and he landed on this spear, and it went into his belly. And we got a CAT scan, and it showed that one of the tines was actually right between his kidney and his stomach and his pancreas. And we took him to the operating room and opened him up. And I had my third-year medical student pull that out. And actually, it didn't hurt anything at all. We just sewed him up, and he went fine. Went home in a couple of days. That's my medical student, and I always like that picture. He went on to become an anesthesiologist. I almost talked him into being a surgeon, but not quite. So that's some of the cool stuff you get to do when you're in medical school. You get to scrub in cases and help out. This is the grossest picture I got. This was a guy that has a condition called necrotizing fasciitis, which you'll read about or see in the newspapers, called the flesh-eating bacteria. So it's a real thing. It's been around for hundreds of years, thousands of years. Some people get this. This guy was really sick, was in the intensive care unit, was on a ventilator, and was dying. And they couldn't figure out why he was dying, but he had a little cut on his leg, and it didn't look right. So they asked me to come and see him. And sure enough, we diagnosed this at the bedside and took him to the operating room. And we had to take all the skin off of his leg and his abdomen, his scrotum, and believe it or not, that guy did great. If we hadn't done that, he would have died in probably about a half hour. But because we got this and we got all that terrible infection out of there, he went on to survive, and he actually did quite well. That's the goriest picture I got for you today. Well, there's a few things that you probably don't know about surgery. I think there's a lot of myths about medicine, getting into medical school, and becoming a surgeon. This is something that I'm sure none of you know, that over the last 25 years, there's been a 25% or 26% decline in the number of surgeons in the United States per capita. And there's several reasons. There's less students going into surgery. Surgeons are retiring a lot earlier than they used to. It was very common to have surgeons work up until they were 70 years old. And now surgeons tend to retire a lot closer to 60. And the population has grown a lot bigger. So we've graduated the same number of surgeons, right? But the population's gotten bigger and older, and surgeons are retiring earlier. So there's a huge need right now in the country for surgeons. So that's a good thing. And there's lots of great jobs out there. You can have your pick of jobs, live anywhere you want, and sort of tailor fit. I work with a gal her husband's a surgeon, she's a surgeon, they have 2 kids, and she felt she was away from home a little bit, so she works 3 days a week. She works 60% of the time. She's a great surgeon, she's a great mom, and there's guys that do the same thing. So it's very flexible. The job market now is very flexible, and you don't have to work all the time and never see your family, okay? There's a lot of myths. One is it's almost impossible to get in. You have to be the very top of your class. Sure, if you're at the top of your class, it's going to be easy for you to get into any residency you want, but you don't have to be like the very top of your class. That's what you want to strive for. You want to do as well as you can in medical school, but you don't have to be in the top 1 or 2% of your class to become a surgeon. You have to be really good with your hands, all right? So the expression in surgery is we can teach a monkey to operate. All right? The technical part of surgery is the least important thing that we do. The most important thing we do is how we think and how we work up patients and how we kind of deal with patients as a whole. The technical aspects of being a surgeon actually are probably the least important. And that will come to anybody, almost anybody, after 5 years of training. I don't think I've ever seen anybody that said, well, we're going to throw you out because you're just not good enough with your hands. Now, certainly, sometimes people that practice and do things with their hands, they might have a natural gift. Some people are naturally gifted at it, where others aren't. But you don't have to. I've had people say, oh, I can't be a surgeon, I'm not very good with my hands. Well, that's ridiculous, okay? A lot of you hear surgeons are really mean and we're not fun to work with. I think that's a myth. I'm not such a bad guy. The students that rotate with us, we have 53 surgeons in our department, and they always say, a lot of them say, well, I don't want to be a surgeon, but you guys were really fun to work with. It was really a good experience. So I think that's a myth. I think a lot of the stuff you see on TV, and I have a little clip from ER I was going to show you about, the real typical mean, nasty surgeon, and I think that myth is perpetuated on television, and I think it's a bunch of baloney, and we're not like that. And that we work all the time and we don't have any fun. I'm just like you. I like to go out and have a lot of fun. One of my huge passions is sailing, and I just took this up since I moved here. I'm new to California. I've only been here for 3 days. I bought this beat-up old sailboat on Craigslist, and it's down on the bay, and I go down. I'd be down there today if it wasn't for you. And tomorrow I'm going to be down there on the back of that boat drinking a cold Pepsi, a couple of them, and I'm going to be sailing all day tomorrow. So there's a lot of fun things I do. This is me scuba diving. I've traveled all over the world. I'm in diving. This is me fishing with my little nephew here up in Truckee. We were trout fishing last year. And it was funny, I'm looking like I know what I'm doing. He caught more fish than I did. Go to Yosemite and go hiking and do lots of fun stuff. So it's not just about work, but I'll tell you, if you're not going to work hard and you're not going to be passionate about what you do, then I don't think you have any business being in medicine, period. I don't care what you go into. I tease all my students, oh, you want to be a surgeon. If surgery's not right for you and you're not passionate about it, you shouldn't be a surgeon. But the same can be said of anything, dermatology or working in the ER or whatever. But I love being a surgeon, and there's a lot about being a surgeon is what defines me as a doctor. I admit people to the hospital if I think they're sick, and I work on them, and I can make them better, and I send them home. A lot of doctors can't admit patients to the hospital. I bet you didn't even know that. So a lot of these hot specialties that people want to go into, they don't have admitting privileges. They can't admit somebody to the hospital. So you have to call another doctor and try to talk them into admitting the patient, which I think is really, I wouldn't like that profession at all. So anyways, my advice to you is just whatever you do, just be passionate about it, and you'll be great at it, whether it's surgery or not. So that's it, and we'll take some questions here.
There's a really good question that's come from the Twitter feed from some of the folks who are watching online. The question is, what kind of balance can be achieved between a surgical specialty and primary care? Are surgeons able to engage in primary care?
Oh, that's a great question. A lot of that is going to depend maybe on the setting where you practice. Maybe in a smaller, more rural practice, you can choose to do some primary care. But as a specialist, as a surgeon, everybody that comes into my office is sent to me by a primary care doctor. So nobody walks down the street and goes, I'm going to go in here and get my gallbladder out. So they go to their family doctor or a primary care physician, and they're sort of worked up and then sent to me for an opinion. Do they need their gallbladder out, yes or no? And if yes, then I'll do it. So when I get that person into my office, I don't manage their primary care issues because they have somebody already doing that. Now, on occasion, I might be on call and pick somebody up who doesn't have a primary care physician, and then I'm certainly welcome to do as much of that as I want to do. Okay? There's a question in the front of the room here. Can I take that one? Yes, sir.
So it looks like you're doing trauma surgeries, and I know that trauma is a 2-year fellowship at general. So did you do that, or what's the separation?
Yeah, that's actually kind of a little bit of a myth, but it's kind of true. Once you become a board-certified general surgeon, you do general surgery and trauma. You can do that. You're trained to do that. Now, if you want, you can go out and get some extra training where you do trauma and critical care, and then you sort of have a board certification to do that. I don't have that, but when I'm on call, I do trauma. So you don't have, but if I wanted to just focus in and just be a trauma surgeon and run an ICU and all of that, an intensive care unit, then I would get that extra bit of training, and then that's all I would do. I did some extra training, and it had to do with the GI and the belly surgery and in education. That's sort of my passion. So I get to do a little bit of everything. So I really like that. It's not quite as mundane to me, so I like that. But those are the sexiest pictures, so you always put up the trauma pictures.
Students are I think they're really enjoying sort of getting a glimpse of what life after medical school is like and what it means to actually get out there into the hospital, into the surgical room and do medicine and do surgery. What opportunities are there for pre-med students to get their hands dirty right now?
Yeah.
Sometimes literally dirty.
Yeah, well, some programs I know it depends where you're at. Every school that you're at should have a pre-med advisor. And that person should be able to direct you into to the community where maybe you can get some hands-on experience. A lot of times there'll be free clinics that are run by medical students, and they would love to have pre-med students come and help out with that sort of stuff. If you can get in to know a physician and shadow them around for a day, that's another way to sort of see what it's like. I know that the AMSA group locally here is very, very active, and they put together a formal organization where they take, I think, 20 or 30 students every semester, and we have it's a pre-med intern program where if you're selected into this program, you get an ID badge, you get some training, and then you follow us around for 4 hours a day for like once a week for several months. So I think the best resource is to go to your pre-med advisor and see what's there. And then if not, maybe just try to find if there's any medical school in your area and there's medical students, any free clinics, those would probably be the best way to go. Yes, sir.
What is the general surgery residency like throughout your years? Like first year you're doing what, and then second and third?
That's a great question. So it's sort of a graduation of increasing responsibility as you go. And it depends on every program, right? So if you're going to be at Johns Hopkins, it's going to be different than if you were at Harvard, and it's going to be different than if you were at University of California at San Francisco. So every program's a little bit differently. Typically, when you come in as a first-year resident, you're called an intern, and you do a lot of floor work. You take care of the patients on the floor, the post-operative patients, you discharge them, you see patients in clinic. And then you'll often get to the operating room and do some smaller cases with the surgeon. So you might do a hernia, you might do breast biopsies, you might do somebody's got a lump or a bump or a freckle that looks funny. So it's kind of small cases. And then the second year, and then you do that in different services. So you might do that with a group of vascular surgeons, then a group of colorectal surgeons, and then you might work in the intensive care unit for 2 months, and then you might go work with a pediatric surgery group for 2 months. And then your second year, and then you might then the same thing happens. And the typical cases that a second-year resident would be gallbladder surgery, hernia surgery, maybe a bowel resection if it was straightforward. So it kind of gradually increases all the way up, and then when you're on call, it's sort of whatever comes in, whatever comes through the door. So that's a very good question.
Generally speaking, what attracted you to surgery in the first place? And then a student wants to know specifically, why did you choose GI, gastrointestinal?
Yeah, that's a great question. You know, the advice I always give my medical students, they say, well, I don't know what I want to do and this and that. And the advice I always give is the advice I took, is I said, just fall in love with something. So it's like when you fall in love with somebody, you can't over-intellectualize it too much, right? You meet somebody and you're like, wow, I got to see that person again. And I think students today sometimes they'll overthink it. And if you're using your brain too much to decide what you want to do, I think you should use your heart to tell you what you want to do. Whatever you're passionate about, whatever you go through and you go, man, I love the people in this profession. I love this. This is what I want to do. And then use your brain to get you there. So I guess I just fell in love with surgery. So what did I fall in love with it about? I love that we actually make people better. I can see somebody and fix the problem. Your appendix is going to rupture. 100 years ago, you would have died. And in an hour, I can take you to the operating room, take your appendix out, and you go home the same day. And you're cured. And it's just such a rush. It's just still, after all the years of doing it, it's just very exciting. I like being in the operating room. I like being able to admit patients to the hospital, like I said that. If you work in the emergency room, everybody sees all those sexy TV shows. The guys in the emergency room can't admit anybody to the hospital. They got to call me and say, I think this guy needs to be admitted to the hospital. And I can say, no, he doesn't. And he goes home. So I like sort of being in control of my patients. So, yes?
Have you spoken to any of your students, specifically female students who plan to have families or get married or whatever in the future? I've spoken with a physician who said out of 6 women in his class in medical school, all of them got divorces by the time they hit residency who were planning on becoming surgeons.
Can I swear on the internet? Can I? Because that's a bunch of baloney. I have half of my residents right now are women. One of my very best chief residents right now is her and her husband, who is also a surgery resident. They had a little baby last year. They're doing great. I have a third-year residence, one of my superstar residents. She's out on maternity leave right now. She's just had her second baby. Now she's got a month off, but she's gonna have to make that up at the end of her training. We don't lower the bar just because you decide to get pregnant or start a family. And maybe that's the best thing or not the best thing to do, but clearly it's done all the time. I think it's a different world today. Absolutely. The chairman, where I was at before I came here to Davis, she was a woman and was married to the program director, who was a man, and they had 3 kids, and they were great parents. They were always doing stuff with their kids. So I think there's some myths about surgery, and I think that's one of them. I mean, certainly you want to be smart about when you're going to start your family. I don't know, starting it in the middle of your surgery residency might not be my decision, but it's a decision for some of my residents, and they seem to do great. They seem to do, I'm sure it's far harder than I can imagine. I would say with regard to who your partner is going to be, don't marry a jerk. I mean, this is 2010. You shouldn't be marrying somebody who says, well, you're the woman, you got to do it. I mean, that's just ridiculous, right? So that's the advice that I've given people along the way, too, is make sure you got a partner that's, hey, this is a 50-50 thing. There's been a new thing that's come down now from the head governing body that regulates residencies now, and they say if it's okay with the program director and it's okay with the resident and they want to make their training 6 years, you can do it over 6 years. So that might be an option to kind of spread your training out a little bit so it's a little bit lighter. Instead of training over 5 years, you do it over 6 years, you might be able to have some more time at home. So I think it would be hard, but clearly you can be a great parent and still be a great surgeon. And my partner that I work with is the mother of 2 kids, and she's a fantastic mom, and she's a great surgeon. She's always helping me out. She's awesome. So that can be done. Don't let these other people and these other groups and these other areas of medicine tell you you can't be a surgeon, because it's just, well, whatever. So just, I won't pick on any groups in particular. Great question. Excellent question. Yes, sir.
With surgery, it seems like it's getting really specialized these days. So what a general surgeon would be doing, 10 years ago, an orthopedic surgeon or a neurosurgeon is doing nowadays. So is there going to be room for general surgery in the future?
Yeah, that's a great question, the future of general surgery. And that's why I guess I never did answer that one point about why I went into GI surgery. But you're right, things have become more specialized, and people, but a lot of it will depend where you live. So if you live in rural in a small town or rural Northern California somewhere, you'll have the opportunity, if you want, to do lots of different things. There's surgeons that do orthopedic stuff. There's surgeons that do cesarean sections to deliver babies. But if you're living in Manhattan, you're not going to do that. You're not going to do orthopedic stuff. You're not going to be doing cesarean sections. You're going to be doing, so a lot of it is depending on the need of the community where you live, what you're doing, okay? But a general surgeon, somebody who trains for 5 years, you can do whatever you're comfortable doing. And that'll sort of be up to you based on your training and your comfort level and who your partners are and things like that. Some of these older surgeons that have trained years ago, they do everything. And they're great surgeons. I mean, they're really fascinating. But if you want to specialize, I just met a woman down in Santa Barbara that's a great surgeon, and she says all she wants to do, she does breast surgery and melanoma for skin cancer. And that's it. She doesn't do anything else. So anybody in town, if it's a bad breast cancer case or a melanoma case, it goes to her. She's the go-to person. But if she gets a bad gallbladder, she's going to send it to somebody else in town. So a lot of it depends where you live and who your partners are and things like that.
There's a really interesting question that came in over the Twitter feed about similarities and differences between interventional radiology residencies and surgical residencies. And I guess I would add to that as well, sort of in this new age of collaborative medicine.
Yeah.
How do those distinctions fall between, say, interventional radiology, surgery, the radiologists, the internists?
Yeah. Well, I think that goes back to what I said before, that this really is a team sport. And a lot of that's going to depend where you're at. I've had the great fortune of working with 2 different places where you had awesome interventional radiologists. So what that is if I might have somebody that has a big abscess after a surgery, they've got a big infection, instead of me going back in and opening them up, they can put them on a CAT scan machine, find it, and put a little drain in through the skin and drain the abscess. But if I'm in rural North Dakota, I don't have a good interventional radiologist that's available, then I might have to go back in and do that. So we work very closely with interventional radiologists. Some of the things that we used to do all the time, the interventional radiologists are doing now. So good, bad, I don't know, but I think I'd be lost without my interventional radiologists. We're a good team. I go down, I know we work together really well, and I think they, where I was at before, they would say, well, I'm biopsying this lung lesion. I'm a little bit worried. I'm afraid I'm going to give them a big pneumothorax. Are you available to come and put a chest tube in? I'm like, sure, give me a call, not a problem. So we really work hand in hand a lot of times. Any other questions or thoughts? Yeah.
Would a trauma surgeon be playing the role of someone in emergency medicine at all? Like, where's the line drawn between emergency medicine and trauma and being a trauma surgeon?
Yeah, it depends where you're at, and there's different levels of trauma center. So UC Davis is a really big trauma center, right? That's a level 1. And if you're at some really tiny little hospital in the middle of nowhere, it's a trauma nothing, right? And then there's like a level 4, level 3, level 2s, and level 1s. So it really depends on how big of a center it is. But emergency room doctors don't operate. They don't go to the operating room. They don't know how, they don't operate. They're not trained to operate. So what they might do in a smaller place is they might, as soon as something really bad comes in, call the surgeon and say, look, this guy's really messed up. He's got blood pressure's low. His belly's distended. I think his spleen's bleeding. We need you in here. And then the surgeon would come in and take over and manage that, and then take the patient to the operating room. The way it works here at Davis is when there's kind of a low-level trauma, the emergency room folks deal with that, and the trauma surgeons don't get involved at all. But when it gets kicked up to a higher level of severity, so, a little fender bender in the parking lot, you got a sore neck, and you say, oh, I was in a trauma. Well, you don't need a surgeon for that. But maybe it's a rollover on the side of, 80 on the causeway. Well, that's going to be a level 1 trauma, and you're met, when you come into the trauma bay, you're met by a team of surgeons. Does that make sense? Okay. Yes, ma'am.
So in life, things don't always go as we plan for it. And so have you ever had this happen, or do you know a surgeon where, you're in surgery and something doesn't go right, or something happens to the patient?
All the time.
How do you deal with that?
Yeah.
Case
Yeah. Well, that happens all the time. And what's really great is you have to know your own limitations, and you ask for help. And I ask for help all the time, and my friends that I work with ask me for help all the time. In fact, I have my boss, my immediate boss, was doing a case about a year ago, and there was something happened, went wrong, and he gets stuck with a scalpel under his fingernail, and it went all the way in under his fingernail. And it sounds horrible, doesn't it? And he was in so much pain he couldn't operate. And the patient, he's halfway through this big operation. So he called me, and I'm at Safeway shopping, and he says, it's like 8 o'clock at night. He's like, what are you doing? I'm like, I'm buying beer. What do you think I'm doing? And he says, hey, can you help me out? I'm like, man, I'm there in 5 minutes, brother. And I showed up, and I'm like, oh, that looks terrible. So I scrubbed in and finished the case for him, So it's not, now, what if you're a solo surgeon in the middle of nowhere? That's a whole different level of stress. So what you tend to do in those situations is anything that looks like it might become complicated is you send those to a larger place where there's other people around. But I'm very lucky here. If I get into a big blood vessel and I can't get it to stop bleeding, I can pack it off and call in a blood vessel surgeon, a vascular surgeon, to come in and help me. And if I get down on the pelvis and I see something that doesn't look right, I did this the other day. I called in one of the gynecologists, and I said, I don't know, what do you think's going on down here? And they call us in all the time. My fiance's a OBGYN doctor, so we're always going in, calling each other in to help each other out. So you just ask for help. It's like anything else, and you have to know your own limitations. And nobody ever faults you for asking for help or asking for a second opinion. In fact, that's a good surgeon that does that. Yeah, it's really good questions. Yes, sir.
I was just texted a really good question. These are coming in from all different angles here. What would a career in surgery look like that combined surgical practice with a focus on public health or a focus on world health?
Wow, that's a great question. I don't know, but I'll tell you this. I have one of my residents right now. She's taking a year off, and she's at Johns Hopkins getting a master's in global health, actually. And she wants to come back and work in the global health scene. I had a resident 2 or 3 years ago, took a year off to do research in the Royal Academy of Infectious Diseases in London, and she worked with some expert surgeon that worked with liver cysts from parasites from Africa. So you can get really specific like that, or you could simply come back and finish your training and go do work in policy or politics or what have you. I think a lot of those jobs in global health, they want somebody who's just really well trained to go and address the needs. And I can't think of anything that would be better than surgery, because the training's a little bit longer, it's a little more in depth, and it's more in a greater breadth of training. But I don't know that I can really answer that question. I think somebody, an expert in global health, would probably be better to answer that. Yes, sir.
How do you deal with, malpractice suits and liability? And I mean, it seems like a big part of surgery. Like, it's a big risk to operate on somebody.
It is, and what you have to do is you have to be really honest with patients and explain all the risks of surgery. Before, even simple, like a hernia or a gallbladder, is explain the risks of surgery beforehand, and you kind of document all of that. And then you can still get sued. And so you have to have malpractice insurance. I work for a university, so that pays my malpractice insurance for me. If I were a private practice doctor, I'd have to go out and buy a policy. I don't know what that would cost, but it would cost a bundle. And you just deal with it. And if you practice medicine long enough, you get sued, and it happens, and you just go with the flow. And sometimes you win, sometimes you lose, but you just keep going. I think studies have shown that if you get along well with your patients, if you explain things to patients, if you go out and say, hey, we screwed up, I'm sorry, I made a mistake, studies have shown that you're less likely to get sued. So there's some things that you can do that are just sort of inherently, maybe more inherent to some people than others. Being honest, telling people you're sorry when you make a mistake. And I do a really good job of setting up before surgery. I said, look, there's a lot that can go wrong, and this is why it can go wrong. You've had this hernia repaired 5 times before, and if you want me to fix it again, you need to understand this could happen, and this could happen, and it could come back again. So sometimes just spending a little extra time with the patients can help, but it can happen to anybody. Anybody can sue you. Just goes with the territory. So.
Dr. Gauvin, can you speak to the future of surgery? We're expecting a hopeful pre-meds in the audience, and they may be practicing surgery 5 years, 10 years, 15 years out from now. What does the future look like?
Onward and upward. I think that the opportunities now for young people coming into medicine, there's a huge demand that's just starting to surface now from the data that I showed earlier, and I think that's just going to get bigger and bigger. So as far as getting a job or getting a residency in surgery, I think that those opportunities are going to be plenty, and I think you're going to call your own shots. As far as where we're going, I mean, it's just extremely exciting, and there's things like robotic surgery that's going on. There's surgeons doing all sorts of different types of research. I don't know. I think it's a great time to come into surgery right now. I just think I couldn't imagine doing anything else. So, yeah.
Do you do most surgeries nowadays laparoscopically, or are you making an incision?
Oh, I do both.
Yeah.
I do them both, laparoscopically and through open incisions. Yeah.
So, like, how does that affect the surgery? Like, how does that affect you doing the surgery? Like, what's harder? Like,
Well, it depends. Gallbladder surgery, we do laparoscopically all the time, and it's pretty easy. It's easier to do it that way for the most part than it is to open them up now. But other things, sometimes it's harder to do laparoscopically, and you get a little bit impatient. Sometimes you just want to say, give me the knife and I'll fix this really fast. But sometimes if you persist, you can really decrease the postoperative pain for the patient. But it's your call as a surgeon. You can always say, I'm not going to do this. I'm going to stop, and we're going to open the patient. So there's advantage to doing things laparoscopically, and then sometimes that's just not the right thing to do. It's better to open them up. So I feel pretty well trained in it, and so I do both. Yes, sir.
Well, I think unfortunately we need to wrap. We'd love to see more gory pictures from you, but that's all the time that we have. I want to thank Dr. Jeffrey Gauvin, Associate Professor of Surgery and the Program Director for the Department of Surgery Residency Program at UC Davis. Thanks so much for your time and for the information that you've shared with us. And the exciting things that are happening in the world and practice of surgery. Thank you all for your continued participation. Your questions coming in through the Twitter feed are fantastic. Your comments are great, so keep those coming as we move on through the day. So thanks again. Thanks so much. Have a great
Thank you.
afternoon.
Thanks for the invitation.